Thank you all for coming. I think we've got a great program for you tonight. We've got some very talented speakers for you. I want to thank the Academy of Medicine for putting this together. It wasn't my idea, it was theirs. And Sue and Ryan, you did a great job for us all. Welcome to the Academy. The Academy of Medicine's been around since 1900 here in Rochester. So back then, there were horses and buggies on East Avenue. So things have changed in those 125 years. The Academy's done great work in the community, always bringing together healthcare providers to collaborate and bring better healthcare to the Rochester area. That's how it started, and that's what it continues to do. Today, the Academy has members from all the healthcare professions. I say all, most, almost all. And it's interprofessional. Everyone sits at the table as peers. We have both hospital systems represented. Everybody works to better the healthcare given in this community. I am a past president of the Academy of Medicine. I joined the Academy because it became an interprofessional group, and I thought it had great promise for the area. I also own Greater Rochester Chiropractic. We're at our location since 2000. I've been practicing chiropractic for 36 years. So why are we all here tonight? That's the big question, right? Low back pain. Well, in your lifetime or your friend's lifetime or whatever, about 4 out of 5 Americans will experience a disabling low back pain episode. We define disabling low back pain as back pain so bad I can't go to work. So it's a pretty broad definition, but it works here. Low back pain is the most common cause of disability and in people under 45. And the most important thing I think you can take from tonight, and I hope that both Kaylee and Dr. Josh will address this, 70% of people who have an initial episode of low back pain, which resolves within 6 weeks, will have a recurrence. That's the big word there, recurrence of that low back pain within 1 year. So what that tells me, and I hope you take away, is that something should be done if you have a disabling low back pain episode. Something should be done to change the underlying biomechanics, change your activities of daily living, change something, or there's a very good chance it will reoccur. The societal costs of disabling low back pain are monumental and really cannot be calculated when you figure in disability, training of new employees, unemployment payments, et cetera, et cetera. That's why we're here. So there are a lot of treatment options. Tonight's program is going to take you from least invasive to most invasive options. Least invasive would include things like physical therapy, chiropractic, self-care, perhaps over-the-counter medications, simple stretching. I was almost going to say Google, but Google sometimes doesn't work for people. Where would your portal of entry into a care pathway be? Well, it should probably be with someone who has the ability to diagnose you, differentially diagnose what's going on, do a functional exam. And that would include physical therapists, chiropractors, some primary care physicians, et cetera. Okay, I think we are ready to bring on our first speaker, Dr. Joshua Rittenberg. Dr. Rittenberg is the owner of East Avenue Chiropractic, been in practice for 13 years. His goal is to empower his patients through education and consistent progress from passive care to active independence. The reason that's important is because of the recurrence thing. His office has multiple options for care. He has massage therapists, physical therapy, and chiropractic on site. He also has great relationships with local medical doctors and is able to streamline or fast-track patients for more invasive types of treatments like injections, surgical consultations, etc. So Dr. Rittenberg will be talking on the role of a chiropractor as a portal of entry provider, meaning you could go there right off the street, you don't need a referral, and that they would be able to figure out what's going on with your back, decide whether imaging is necessary or referral further up the chain. Dr. Rittenberg.
Thank you guys all so much for having me. So I got quite a bit of meat to go through. I have a lot of ground to cover. So if there's anything that I mention or any topic that I get that I didn't really go into too much depth with, please feel free to ask questions later on. So why see a chiropractor? Chiropractors have a 4-year doctorate. We graduate as physician level providers with diagnosis in our scope, which means you can come to us having no idea what it is, and we'll do a really well-rounded exam. We'll put you through both functional testing as well as possibly imaging diagnosis. We're trained in managing complex disorders and in actually implementing non-invasive techniques. We could order x-rays, MRIs, CAT scans, ultrasounds, and this makes us a pretty perfect portal of entry doctor for these types of MSK or musculoskeletal problems. Chiropractors oftentimes will co-manage with physical therapy, primary care physicians, massage, acupuncture, pain management doctors, referral with ortho neuro. And one of the benefits of seeing a portal of entry doc like us is that not only can we possibly fast track it, but the doctors we refer to know that we've done a thorough enough evaluation that means you should be at the place that you're at. Sure. Sorry about that. Obviously, we want to help people decrease pain, improve function. And one very important note is during this previous number of decades where we've seen an increase in the amount of opioids and pain medications that are prescribed, patients who with low back pain who seek out chiropractic care first or physical therapy first usually have about a 50% less likely to fill opioid prescriptions. Chiropractors are trained in lots of adjunct therapies, physical therapeutics such as ultrasound, electric stim, cold laser, taping, advanced soft tissue therapies, including active release technique and instrument-assisted techniques, and some of us specialize in peripheral nerve entrapments as well. We are thoroughly versed in therapeutic exercise and stretching, helping you to alter your normal daily activities to make them more comfortable. Just a disclaimer, if you've ever in a serious injury, if you actually have a car accident or a trauma and you fear that there is something seriously wrong, do please seek out emergency medical care in a hospital or urgent care. And then once those kind of dangers are ruled out, you're definitely more than welcome to come visit one of us. The spine consists of 24 different bones stacked on top of each other. All the way at the very top, we've got 7 cervical vertebrae, mainly there for bending the head forward and backward and rotating. The thoracic spine has 12 vertebrae. The ribs attach at every single level, so the thoracic spine is very, very stable. We don't see very many traumatic injuries there. And at the very bottom, the lumbar spine, there are 5 vertebrae, and in between each of these vertebrae are spacers called intervertebral discs. These particular spacers have shock absorbing qualities. People usually view them as shock absorbers, but they're there more to maintain space and integrity of the spine so that in between each of those levels, you've got spinal nerves that are able to exit unimpeded. Looking at the disc, it is essentially concentric fibrous rings that are glued or laminated together surrounding a more kind of gelatinous type nucleus, and the spinal nerves exit out between each of those. They are hydraulically pressurized, so they do accommodate to compression, but they do have a failure point and they can bend only a certain amount of time with poor mechanics before they start to fail. We're going to skip on through there. Last to mention in the anatomy is the pelvis and the sacroiliac joints. The pelvis is comprised of these 2 wings of the pelvis. Sandwiched between them is a triangular shaped bone called the sacrum, and the hips articulate with these. So they're the foundation of the spine. They have to move just as well as the spine does. And if your hips don't move quite as well, which is a common cause of low back pain, you'll start to feel that move up the chain towards the pelvis and the spine. There are some congenital abnormalities to speak of, scoliosis probably being one of the common ones, and we can certainly touch on those later. there are normal age-related changes we see in the spine. The normal disc should have a certain height over time with repetitive movement, with gravity, prolonged sitting, previous injury. We start to see thinning discs. We see bulging discs naturally in our population. And every decade of life, we see 10% more incidental findings of disc bulge. As that quality of your cartilage decreases or changes, we start to see increased bony growth, and we then start to see some narrowing of those spine canals, both the nerve openings as well as the central canal called stenosis. Disc herniations are a very common cause of pain. Here, all the way to the left, we've got a normal looking disc. As load and pressure over time start to deform the inner part of the disc, that kind of gelatinous material seeks the path of least resistance, which tends to be towards the back of the left or the right side. And as that disc herniation develops, you start to see it push out towards one of those nerve roots. Secondly, we're going to talk about the muscle system, okay? Muscles are there to actively stabilize your skeleton. They're there to create and enhance movement, help to maintain posture, it's integral in circulation of blood and lymphatic tissue. It produces heat as well as helps to speed up your metabolism and protects your organs and delicate nerves. So when we see someone in our office, about 90% of our diagnosis usually comes from the history itself. So having a really detailed history takes up probably more than half of my visit with someone, especially someone with recurrent pain. During that time, we may look at previous imaging you've had. We may discuss future imaging, but we're going to go through a pretty standard type of questioning. It's going to look very similar to if you were to see an orthopedist or a neurosurgeon. We're going to go through a very detailed history and then a physical exam as well. We're going to try to rule out any red flags that would make us want to get you out of our office to an urgent facility. Things like a recent trauma or injury, pretty significant loss of ability to go to the bathroom or control your urine, progressive worsening or weakening in the legs, back pain that's accompanied by other symptoms such as unexplained weight loss, fever, chills, severe pain at rest, a history of cancer or metastasis, recent infection, sudden onset of severe tearing or pulsating pain in the abdomen, and also a history of drug use or steroid use. So chiropractors are qualified and have training to take x-rays on site in our own facilities. It's not something that I choose to do. I do like to have another set of eyes on it. But medically necessary imaging should be performed if any of those red flags I just mentioned above are there. But we do not jump to order imaging right away when someone has low back pain. The guidelines say that in absence of those red flags, we should be waiting somewhere around 4 to 6 weeks. And if we start seeing some functional improvements, not just in pain, but in the way that you're able to function in your normal life, we're going to delay imaging because we know we're going to see something on it. However, if you don't respond to care or you have some progressive changes, we'll likely refer out for some imaging. If you're greater than 50 years with a history of cancer, I'm probably ordering imaging. If you've got progressive neurologic pain or weakness in an extremity, I'm going to order some imaging. And if you have a history of other previous surgeries, we'll likely want to visualize that as well. Common low back diagnoses, and I think some of the other speakers tonight will go over some of these, but there's some acute presentations. I bent wrong, I slept funny, and these can be sprains and strains of muscles. We can have this discogenic pain, which can come on spontaneously. The facet joints, golfers, people who work in the yard tend to experience these. And then there's a lot of chronic and recurrent things. Just like Dr. Lang said, people who have had a severe episode of low back pain are more likely to have recurrence. And there are some treatments which people opt to undergo at some frequency ongoing because it's a sort of physical medicine where we can directly target those areas and structures that sometimes need care on an ongoing nature. A chiropractic treatment plan oftentimes includes some sort of manual hands-on therapy. There are lots of different low force and high force techniques we may use. There's spinal decompression tables and flexion tables. Most chiropractors will implement some sort of hands-on soft tissue therapy as well. During those treatments, there's oftentimes some sort of movement-based therapy where we're trying to create some elongation of a tissue, which may not be the one that you think needs to be treated, but mechanically, we need to be able to restore some normal function to those tissues, we'll likely address some fear avoidance. Anyone who's had an episode of low back pain starts to develop some fears with certain movements, and oftentimes we're going to be addressing that component of it as well, because movement is healing. We want you to be moving. Bed rest should be limited. Moving to normal activity as quickly as possible is the best way to get over an episode of low back pain. And we'll recommend home care, such as superficial heat, stretching, and modified exercise. Referrals to physical therapy from my office are incredibly common. I refer to physical therapy multiple times a day because once I've gotten to the end of where I think this person needs some sort of hands-on care or reinforcement that they're going to be okay, they need to build some resilience, some tissue tolerance, and disrupt that fear avoidance. So whether it's physical therapy or a personal trainer, they need to get moving and they need to build some independence into their life. Pain management, referral to a PCP for some co-management if symptoms are worsening. And then if we really have some progressive changes, I'm going to be referring to a neurosurgeon or orthopedic surgeon. But just keep in mind that all of these different referrals moving up this ladder of invasiveness are meant to get you functional enough so that you could be more successful seeing less invasive providers like myself or physical therapy.
Thank you very much, Josh. That's great. Our next speaker is Kaylee Spoda-LaRue. Kaylee's the owner of Star Physical Therapy. It's very well reputed in the Rochester area for probably 25 or 30 years or more, probably 40 years. Okay, 40 years or more. Her group offers patient-centered care, and I think any of our speakers tonight, patient-centered care is kind of our mantra. You know, it doesn't matter about anything except what's best for that patient at that time in their care journey through the system or through their own problem. The things they offer at Star Physical Therapy include aquatic therapy, personal training, massage therapy, infrared sauna, and acupuncture. And I just want you to appreciate that our panel here, all of us believe in interdisciplinary approaches and collaboration, and that is how we are able to, and other community providers are able to offer the patient-centered care you need. Because if you need acupuncture, if you need massage, or you need aquatic therapy, we have ways to provide that for you under one roof or with people we know. Kaylee will be discussing the role of physical therapy in the management of low back pain and how active care and exercise plays a major role in recovery and prevention. Kaylee, come on up.
Thank you for having me. Thank you for the introduction. Very nice introduction. So I'm here to talk about physical therapy and the role it plays in treating low back pain. I have a lot of experience treating many types of low back pain. It comes in all different presentations and all different types of people. And if I can have you take two takeaways from anything that I say today, it's that it's not all the same, and there's not one remedy for every person or every situation or even every diagnosis from a standpoint of your medical diagnosis, a disc herniation, spinal stenosis, etc. The answer is different for every person, and you should seek guidance to find out what the right answer is for you. And the other piece of it is that movement is a key component to treating low back pain and preventing recurrence of low back pain. As Dr. Lang mentioned earlier, it's very common for people that have one experience of low back pain for it to creep into your life, and sometimes it can take over your life. And anything that you can do to prevent that from happening, I think most people would try to latch onto, and we can help you with that. It can be very scary to experience an episode of low back pain, and so a physical therapist is there to provide you some encouragement and direction in terms of how to manage it. So a concept that I visit very frequently with most of my patients is just the concept of stress on your body, and that's how injury occurs. And it's not always one big event. It's not always one big, lifting an object. Sometimes it's lots of little tiny stresses that build up over time, the straw that breaks the camel's back, so to speak. And these injuries can occur to different structures in your spine, as I said before, and those different structures, depending on what the injured structure is, it presents in a different way, and it needs to be addressed in a different way. And that can include the discs that Dr. Rittenberg was just showing you during his presentation, the joints, the nerves, the muscles, and sometimes more than one component, oftentimes more than one component. So in the initial stages of recovery, you need to protect those injured structures. You need to identify what they are, and you need to make sure that you're avoiding, picking the scab, so to speak, so irritating the thing that's trying to heal. And during that inflammatory process, your threshold to be able to take on stress is lower than it would normally be. So, an activity that used to feel like nothing is all of a sudden daunting, and you need to figure out how to do it. There are ways to promote protection of those injured structures through movement, and there's ways to calm those injured structures down through movement and education in terms of how to manage it. So then as your physical therapy progresses, what you do is we continue to reassess together. So we say, how are these things going? How are these movements going? What should you add into your day? What should you take out? And how do you re-engage in your daily life? What types of things should you be doing or not doing? What should you be aware of as you're doing those things? What should you be thinking about? And then, of course, looking at, your physical presentation and restoring whatever mobility has been lost, taking a look at where your strength stands. Strength, as Dr. Rittenberg the muscular system provides that support structure for your spine. So trying to create activation of those support structures is so important. Again, not only during your recovery, but to prevent future recurrence. And then, what we do is progress you to an independent program that you can keep doing on your own, and, that can help you, help your body feel good. As I said, why physical therapy? Why chiropractic care first? And the answer is because most back pain can be treated conservatively and managed conservatively. We are specialists of the musculoskeletal system. That's what we do. That's what we look at. We see it every day. We see all different types of bodies, all different types of movements, and we can identify where things are going wrong. We are also trained to identify, those red flags that were covered in the last presentation. So we can identify who needs to be referred out to the different provider, and it's a more efficient referral in that case, because if that referral, if you're getting referred there, that's where you need to be, instead of, going and having it you not being ready for that care. And then, we have a lot of time scheduled to evaluate and really discuss that, physical therapists and chiropractors, we have the luxury of scheduling our patients for a long period of time to be able to discuss their history and kind of dive into every single aspect of things that are contributing to their problem. And then the regular follow-ups help us track how things are going and provide guidance and support and adjust the treatment plan accordingly. Of course, physical therapy is going to encourage you to move and take an active role in your recovery and an active role in the healing process. And all during your sessions, education, encouragement, and empowerment that you can do things that maybe you think you couldn't do. And I think that's really important in terms of re-engaging in your life. So what happens during an assessment, like I said, it's usually 45 to 60 minutes where we take a very thorough history. We ask lots of questions and dive into what's going on, what's happening, and we identify how it's limiting your life and where your goals are. And like I said, that's very individual for every single person. They're starting from a different place and they want to end up in a different place. And then, after the movement exam, we'll take you through and see where your movement is, how it's, what's going wrong, what's eliciting pain, what isn't. And then we'll provide education on how we think you should move forward, initiate an exercise prescription, and then discuss where your plan of care is going to go. So to break that down further, what we're looking for in that history is, how did the injury happen? And, was it one big event, or was it something that occurred over a lot of small different things? Has it been going on episodically for a long time or not? What are the exacerbating or alleviating factors that are playing into your day? What have you found makes you feel good? What have you found makes you not feel good? And then the behavior of your symptoms. So, how you're describing things and what times of day you're experiencing these things. And that's all going to guide the physical therapy diagnosis and your treatment prescription. And during the movement exam, what we're looking for is if there's a direction of movement that feels better or that creates a response in your symptoms that's optimal for recovery. And then we're looking for the different types of movements that provoke or alleviate your symptoms and the quality of your movement. So how is your movement looking? Are there things that are going wrong in the way that you bend or the way that you sit that could be contributing to the buildup of stress on whatever tissue is injured? And then, of course, your range of motion, mobility, flexibility, and your strength and how your strength balances out. And then, of course, palpation of the structures that we're trying to identify. So after all of that, where we're coming is to a conclusion, and I can get into this more if you have questions about it, but essentially we're categorizing based on the exam findings between these things, and these five kind of designations can overlap. There can be multiple things present at once, but discogenic pain versus a joint problem versus neurologic pain versus myofascial pain versus dynamic instability. And essentially we're going to be addressing each one of those factors if they're present in your provocation exam very differently, which goes back to the point that there isn't one remedy for everybody, and then whatever we're addressing, that person's going to start from a different place. So to kind of dive into management strategies a little bit more, I get asked a lot, should I use heat? Should I use ice? And heat tends to be something that will help you relax. It helps promote blood flow. It helps promote relaxation of tissues or really tight muscles. Whereas ice should be used in usually a more acute situation or inflammatory situation. It can also dull your sensation a little bit to be able to manage pain. So we'll talk about if you should use that or not, if you should incorporate that into how you're managing things. We'll dive into your daily habits. Like I mentioned before, are you sitting at a desk all day? And, should you maybe stand up every 20 minutes? Or are you, constantly carrying a kid on your hip? Are you carrying laundry up 3 flights of stairs? Whatever it is, we're looking at, how are these things impacting the problem that you're having, and how can we maybe modify them or make some changes? And then, a common piece of advice, especially for more acute episodes of low back pain, is avoiding flexion in the morning, which is bending in the morning. When you first wake up, everything is stiffer. That happens even with the healthiest body or a body that's not injured, and you're going to be more vulnerable to re-exacerbating your problem in those first hours of the morning. So if you're, maybe the first thing you do is sit down at your computer after you wake up, that's problematic, right? That's sitting, that's flexion. Or maybe the first thing you do is bend down to put your slippers on, whatever it is. A lot of little things can add up to a bigger problem if you're not aware that they're contributing. And then we'll make postural adjustments. So maybe we'll take a look at how you're sitting at your desk or how you're sitting in your car, or are there ways that we can change or provide support or make adjustments to those things. And then just guidance on should I be shoveling the driveway? Should I be doing these different things? And advice that's personal and dependent on your problem. On how you should do that. And then, of course, if you have, you play pickleball, that's apparently all the rage. But, should I play pickleball? Should I not play pickleball, et cetera? And education on movement control. So when you have a pain experience, your muscles respond, your body takes the path of least resistance. I think Dr. Rittenberg used that same phrase. And you adjust and you accommodate, and you don't even realize those things are happening. And when those things are happening, you're deactivating and not using certain muscles. And so you need to re-educate your brain to engage those muscles again, to help create more normal movement patterns and help you move into your life with good quality of movement, good body mechanics, et cetera. So we teach activation, which means we're educating those muscles to fire again in a more controlled way that's not eliciting a pain response. And then acquisition, where we're trying to apply that muscle activation into some simple movements. And then assimilation, the more that you're practicing these movement patterns, the more that your body accommodates and you can do them automatically and you don't have to think about it as much. And that's the whole idea, and that's where it plays into prevention. If you're establishing these good movement patterns, it's going to help you maintain better movement patterns in your life, which helps you lessen the chance of recurrence of back pain. Okay. Sorry, I know I'm talking a lot. Okay, so then we'll get into the exercise prescription that's based on whatever we're finding. So maybe it's a simple core stabilization exercise, or maybe you have a more advanced person that can tolerate a lot more. We're going to take a look at where they are and start them there and look at where their problems are and give an exercise prescription that's based on that. Treatment can also include some manual therapies, some hands-on therapies, traction, joint mobilization, soft tissue mobilization, stretching. Some physical therapies facilities have aquatic therapy. We have a pool at STAR, and that can be very useful in either more acute situations, or maybe there's other things going on in addition to an episode of back pain where it's easier to move in the water. The water provides buoyancy to unload your joints, and the warmth of the water can help your movements become easier. And then, it may include use of heat or ice or electrostimulation. Combined e-stim and ultrasound can be good for trigger points. And then, of course, recommending any sort of support recommendations or sometimes kinesiotape techniques. And then, the movement prescription is really the key and cornerstone to what we're going to try to do. And like I said, that's different for different conditions. So for example, if you're diagnosed with a disc problem and that disc is moving back into the space where that nerve is becoming irritated, then in many cases, as you're getting out of your acute stages, providing movements that are the opposite of the movement that got you there, which is a lot of repeated flexion, incorporating some extension into your day can be very helpful in relieving that. And, the opposite is true of typically for, a person with spinal stenosis, where they have degenerative change that's narrowing the space where those nerves are, and we need to open them up, and we need to look at factors. So that would be moving your spine in the opposite direction, maybe alleviating for your problem. And then, the mobility limitations in your hips affects the way that your spine moves. If your hips aren't moving well, that's going to affect the way that your spine is moving or not. And so oftentimes if you're, the analogy I give all the time is if you have a spring that's end to end and you have one really stiff part of the spring and you keep moving it from end to end, you're not going to move in the stiff part and you're going to move excessively in those other parts of the spring. So looking at where that movement restriction is and trying to balance out how that movement is occurring is very important to how well you're going to be able to recover. And then looking at painful postures. So, where are these postures playing in, and, how can we change them and how can we adjust? And then, of course, core strength. So the muscular system, and it's not just your abdominal muscles, it's everything from your diaphragm to your pelvic floor, and it's how it all works together, and it's how you can create pressure in that area to create protection for the spine. And especially after an episode of back pain, it's hard to figure out how to reactivate those muscles. And so, getting some direction on how to balance all of those things out can be very helpful. And, that plays into strengthening your hips and your functional movements as well. So it's not just your core, it's, maybe it's your lower body that needs some attention as well. And then, of course, looking at any movements that are contributing. So, how are you carrying your kid on your hip? How are you carrying the laundry basket? Taking a look at how maybe those things can either be modified or improved based on your body mechanics. How are you bending? How are you sitting, etc. And then, a couple other points about prevention is that it takes less time to lose strength than it does to gain it. It takes work to build strength. And, if you want to be able to prevent episodes of low back pain or knee pain or hip pain for that matter, that is all relative to how much stress your body can take. And you're going to be more vulnerable to that stress threshold becoming a problem if you're not challenging your body. And so, it takes work to maintain strength and mobility. And as you get older, that doesn't get easier. As you get older, there's a natural loss of strength that occurs in all your tissue. And so in order to maintain that, moving your body and challenging your body is so important. And exercise is one of the most impactful things you can do, and it doesn't have to be a lot. It could be, as little as 90 minutes a week that you're walking. That's something. Your bodies are meant to move, and the worst thing you can do in an episode of back pain is not move your body, because everything is just going to get stiffer and weaker, and being able to reintegrate into movement sooner is always very helpful. And like I said, this can be different for every individual. So seeking the help of a professional is oftentimes very important in order to get, to not waste time and get back into your life as quickly as you can. And then, the other pieces that I think are important to mention that can be an issue that plays in, in bigger roles or not for certain individuals is good sleep and nutrition. And all of that is part of the picture when you're meeting with a health professional that wants to understand the big picture of your life and how it's impacting your ability to participate in the things that you want to do. And, we're trying to put the puzzle together to get you to be able to do those things. So go seek physical therapy or chiropractic care or, a health professional if you're having an episode of back pain that's lasting long or affecting your life. So that's all I got.
Thank you very much, Kaylee. I hope that you take home from that the job of the provider you seek care from when you decide to see someone is that they meet you where you're at in terms of your life and your pain and what your functions are, and that between you and them, you establish realistic goals. For some people, that might be they want to run a 10K. For other people, I just want to be able to go to Wegmans, right? So that kind of dialogue and communication is critical for a successful outcome when you seek a provider for back pain. Our next speaker, Dr. Jim Snyder, is a faculty member at University of Rochester Medical Center in the Spine Center there. He offers non-surgical options. Non-surgical means a lot of things, but I'm going to paraphrase here a little bit, Jim, and say a lot of what he does is use medications of different sorts and injections. And that would be the next level in terms of invasiveness that you might go to should conservative options fail. The injections work really well for sciatica or leg pain, one or both legs. And if you go to a responsible provider, they'll know that that is something you would need. He's going to talk tonight on over-the-counter medications, prescription medications, and different options for injectable medications. Jim, come on up.
Okay, so while I could talk about a lot of things we've talked about before, we figured that it would be not that great of use of your time, and you probably get bored if we kept talking about the same things. So we're just covering the medication procedures like Les mentioned. Starting with our over-the-counters that we all know and love and we use all the time, but sometimes I'm surprised how often people don't really know what these things do or what they can and can't take and what they should and shouldn't take together. So starting with acetaminophen Tylenol, a lot of times your doctors will like you on Tylenol because it's something that's very minimal long-term side effects. It's something that is one of those few things you could probably take on a daily basis for most people, and you're not going to see any deleterious effects to your health because of that. Now, it is cleared through your liver, and so if you already have liver problems, then you probably shouldn't be taking it. I'll preface all of the things I'm saying about medications is that I can't tell you for your specific, family member or yourself what, based on your medical history, what you can and can't take, but that's always best to go through your family doc. So the Tylenol is nice because it's minimal on side effects, and Tylenol is also nice because it's unique. There's nothing else that's like it. You can take it with basically anything else. So for these reasons, we tend to like it. Then we get to our NSAIDs, our anti-inflammatories, and everybody loves their anti-inflammatories, and a lot of people don't really understand that these anti-inflammatories, like, well, I got it over the counter. What's the matter? Why can't I take a couple of these every day? It helps me feel better. Well, what can happen is that as you're taking these every single day, it's kind of a slow tax on your blood pressure and your kidney function, some of these things that you don't really understand. It's like, well, that's probably happened to somebody else, but I'm not taking that much. It's just a couple Tylenol. There's a couple of Advil I'm taking, so the Tylenol, why does that matter, doc? So there's a million kinds of these. There's over-the-counter anti-inflammatories. There's prescription types that you can get. Ultimately, there are anti-inflammatories and how they're working, but we want to be mindful of what we're taking them with and how often that we're using them. Often medications in general, not a great long-term option. I mean, much better. I understand it's very easy to be like, well, exercises work, doc. Can't I just take a pill? Don't you have a pill for me? I mean, that's easy. We'd all like that, right? But I'm not doing my job, and the other providers aren't doing their job if we're just shoved pills at you. You're not really telling you what's wrong with you, and how do we make that go away? Because it's better to have no pills than having pills every day. Topical treatments, it's for heat and cold. It's been covered a little bit already, so I won't redo that. But ultimately, there's a million and one things you can get at the drugstore that topically you can put on your back or this, that, and the other aches and pains. The bottom line is that there's no good medical evidence that any one of them is better than another one. So it's whatever works. If you find something that works for you and it's worth what you're paying for it, use it. Use it as directed, but use it. And if it's not working, they don't feel like they're doing anything if you're not getting any benefit from them. But there's plenty of kinds of them. Then now we're getting to the more fancy medications. So these are more prescription type medications, neuromodulators. So these are medications that tend to work on trying to make nerves a little less finicky, make those nerves not scream at you quite so loudly. Most common is gabapentin. There's a couple different types of them. They work a little bit in different ways. These are things that tend to be taken more regularly. Often they don't have very nasty long-term side effects, which is why we can use them regularly. They can overall, they tend to have some cognitive side effects. So some people feel that, may affect you. So you don't feel a little fuzzy-headed, might be a little drowsy. None of these have addiction problems. They're not going to be habit-forming, behaviorally habit-forming, but some of them do have some street value because some people like that fuzzy-headed feeling, and so they'll pay good money for it, even though you shouldn't be using that way. Then we have muscle relaxers. Now, what I love about muscle relaxers is that there's actually only one muscle relaxer that actually works on the muscle. All the other ones actually still work on nerves. So they all work in a little bit of different ways. Again, they have a greater variance. These can be even more sedating. Again, not going to be habit-forming. They're not addictive. A lot of people think that, well, I can't be on a muscle relaxer. I'm going to get addicted to it. No. You're not going to get addicted to muscle relaxers. Again, they have street value because some people like that little fuzzy-headed feeling that they can get with these. And so if your doctor doesn't like continuing to give you these forever and ever, that's probably part of the reason why. Not that they think that you're giving it to other people, but just that we don't want people to get in that sense where I just use that as an escape and not really what it's meant for. But these tend to be more of an as-needed type of medication that you're using as compared to the neuromodulators, which tend to be more regular where you take it like clockwork. Opioids. Okay, everybody has their own stories about opioids, and we see all the Netflix specials, and we see everything that's happening with opioids. When it comes to back pain specifically, so this trial that I have up here, OPAL trial, so the Lancet is the #2 medical journal that exists in the world. It is one of the creme de la creme medical journals that we have. And they did a randomized placebo-controlled trial. Now, that may not mean a lot to the lay public, but ultimately that is a creme de la creme study. That's the type of studies that we as physicians love because it's very, very well designed. Ultimately, I'm going to read this verbatim, and I've quoted it here. Opiates should not be recommended for acute, nonspecific low back pain or neck pain, given that we found no significant difference in pain severity compared to placebo. Now, I'm not trying to tell you that there's no use for opiates for any patients. I can tell you that because of this and because of studies similar to this, personally, I don't prescribe them. My job is to try and improve your pain, not just shove pills at you. That's what we're here to do. Most of the time with opiate-type medications, it's something that's prescribed by either a true pain management physician, a palliative care doctor, or your primary if you've gone through specific conversations with them. So I know there's people that probably have some chronic pain, have people on opiates, but the reason why we tend to not like them for this is that despite how much everyone feels they help with their pain, when we do good studies, we don't really find that follows through most of the time. And on addiction risk, that's some scary stuff. And that's something that I have to keep in mind and that other physicians have to keep in mind when prescribing these things, is that no one thinks they're going to get addicted to a certain type of drug. Nobody goes into it expecting that, but on the tail end of it, when we go through our medical training, we see what can happen in those things. And obviously the overdose deaths are just going skyrocketing. And so if you feel like you're in significant pain and your doctor is saying you can't have an opiate, it's not that they don't care, it's probably that they do care. Now we have medical marijuana. Now this is, again, the latest rage. Well, I can't have an opiate, doc. Can I have medical marijuana? My grandfather used it. I use it, recreationally, and it works. Why can't you just give me some of that? Well, maybe it helps, maybe it doesn't. We don't know a lot right now. I mean, it's not something that's been studied very well in the past, and even the studies now that are going on are comparing it to things like opiates in more chronic pain. That's more of a cancer, end-of-life care type of a pain rather than your everyday back pain that people may get. So at this point, if it helps you, usually I say, sure, go for it. But it's not something that I can tell you that there's medical evidence that shows that it works for back pain. So I'm not going to tell you yes, I'm not going to tell you no. For me, I can't even prescribe it because why? I have a medical license in New York, but marijuana is not federally legal, meaning that you need a special license from New York to actually prescribe it. So I put a link at the bottom of this, but essentially if you go onto the New York Gov health site, they have a list of providers that do have marijuana medical licenses for true medical marijuana, if that's what if that's what you're looking for. Now, medical marijuana is different than the cannabinoids, and cannabinoids have CBD, and CBD comes in pills, and it comes in ointments, and comes in topical type. Many types there's many types of ways of getting your CBD or getting your THC from your marijuana. Ultimately, the studies at this point have some weak evidence that maybe there's some benefit in more chronic type pain on non-inhaled types of THC and CBD, but it's really something we just don't know that much about at this point. And so I can tell you that if it helps you, great. But it's not something that your doc is typically going to recommend you try unless we're out of options because we don't have a lot of good evidence that they work. So those are the medications. Now we get to the injectable type, the injectin type things. Epidural steroid injection. So what does that mean? Everybody says, oh, I got an epidural or I got cortisone. And people throw around these terms. Nobody really knows what we're talking about. So epidural is just a space. It's a space if you're having a baby, then that's where they put the numbing medicine, and it's a space that we can put steroid in at particular points if we believe that there is a nerve getting impinged there that's causing your pain or something in that spot. So sciatica, disc herniations, these are things that most likely tend to respond to these. Epidural steroid injections have the best evidence for pain that's going into the leg. So when we're talking about just back pain, it's something that a lot of times you say, well, I need an injection. My buddy got an injection and all his pain went away for the rest of his life and he won the lottery and he married a supermodel and I need an injection. Maybe you need an injection. The first question is, well, why are you having pain? What is causing your pain? And then maybe an injection is warranted for that and maybe it's not. And part of the problem is that there's certain things that The leg pain tends to be the easiest pain to get rid of because it responds to things like injection. And Dr. Reed will talk about surgeries, and there's good evidence that surgeries can help with that as well. But when it comes to just the back pain, that's where these things get a little bit not quite as good as they were before. Now, I didn't mention steroids as a pill that you could take. Why? Steroids can be taken in pill form. They are great anti-inflammatories. The problem is that they're also very, very nasty for you, particularly over long courses of time. And so it's something where, personally, I have good evidence that shows that if you're going to respond to a steroid, I have the skills and I can put it right where the problem is, rather than give you pills over the course of a week or a few weeks, because I know what that can do to you otherwise. And there's a lot of bad things that steroids can do for you. In terms of the dosages that happen, people say, very commonly ask, well, wait a second, but you're going to put steroid here, and what if I need another injection, another one? You told me steroids are bad for me. The amount of steroid that gets used in an injection is typically about 1 day's worth of the pills you might take. So just saying, doc, I got some pain, I can't wait for physical therapy, I can't move, I can't get the MRI, I can't do any of it, I need the steroid pack of the week because that makes me feel better. Getting injections over years is probably the same amount of steroid as you get in that single steroid pack. And so if it seems like something that, again, your doctors are not giving you, that's probably why. Then we get to fancier, even more fancy procedures. So radiofrequency ablation, very fancy medical words, mouthful. What does it mean? So for people that have arthritis in their back, you have joints in your back that Josh talked to you about, and those joints can get arthritis. All joints can get arthritis. What can that happen? What can that do? Well, that can give you back pain because you have arthritis. Now, the bad part about arthritis is that we can't make it go away. There's no reversing that wear and tear on those joints. The good part about arthritis is that it's not dangerous, it just hurts. So because of those two things, I can't make it go away, but it hurts. What we do is we shoot the messenger. Now, that doesn't mean you or your grandmother, whoever's coming in with the back pain. What we're talking about is that coming off those joints, you can see on the picture here, is there's these little nerves that are in white, and those nerves are messengers. They send the pain signal from the joint, and they tell you, hey, you have arthritis, and it hurts. This is not a message that you need. We likely know you have arthritis, and we already know arthritis hurts. So it's not that the nerve is doing anything bad, it's doing its job. So what we do is we burn that nerve so that it can't do its job, because the arthritis is going to be there no matter what we do. So that's what radiofrequency ablation is. Despite the fact that we are burning a nerve, it's only semi-permanent. And what I mean by that is that that nerve likes to go back and do its job because your body is trying to do its best and not understanding that that was something you did on purpose. Luckily, though, this is what we call a percutaneous procedure still. So there's no incisions, no scalpels at the end. You know, you get poked with a needle, and at the end of it, you get a Band-Aid and you get to go home. So no surgeries, for me anyway. When it comes, then we have spinal cord stimulators, and this is the latest and greatest in terms of fancy technology that happens when it comes to, I would say, the non-surgical treatment of back pain. Neuromodulation, spinal cord stimulators. So the way the spinal cord stimulator works is it's actually, it's quite funny. So we all remember those rotary phones we used to have where if I'm on the phone talking to somebody and you pick up the other phone in the house and you start talking to the other phone, I don't know what's being said anymore because there's just too many people talking at once. That's what a spinal cord stimulator does. Your nerves are trying to send a pain signal and your brain interprets that signal. And the spinal cord stimulator just picks up the phone and just starts yelling into it, and your brain can't make sense of what's being said, and the pain goes away because it can't actually interpret that message as pain. It's kind of a neat thing that happens. These are something that do eventually become permanent implants. So there's a trial and then a permanent implant. There's a battery that goes along with it. Some of the batteries are rechargeable. Some of the batteries just last for a certain amount of time, but they all have to be replaced within it eventually. But this is the latest and greatest, and there's different types of stimulators, but usually this is a permanent something that's implanted into your back, into your spine. So usually this is, again, as Dr. Lang talked about, we're kind of slowly creeping up that level of invasiveness, and this is neuromodulation. Spinal cord stimulators are actually most commonly used after some type of surgery has failed because most people don't want something in themselves permanently. So that's all I have, and I'll talk to you later when we do the panel.
Okay, our next speaker, Dr. Patrick Reed. Dr. Patrick Reed is a neurosurgeon. That doesn't mean he just works on backs. He works on brains and peripheral nerve entrapments as well. Nerves anywhere in the body, pretty much, that can get messed up. He did his residency at the University of Rochester, local, and then went to Long Island. And like so many people that live in Rochester and leave, he came back, decided to make a practice here, and we're very happy that he is. I send him patients somewhat frequently. And he is very conservative in his approach to surgery. I've sent him patients I was convinced needed surgery, and he said no. So I think that speaks loudly for his integrity. He's going to speak on when you might want to see a surgeon. He's going to speak on what information you should bring with you or what he should have to make his decision whether you're a good surgical candidate or not. When you might need surgery, what makes you a good surgical candidate? What are some of your surgical options? There are plenty. What are the risks? Have we moved from least invasive to most invasive? We mean we're moving from least risky to most risky. So what are the risks with spinal surgery and the different forms of spinal surgery? What are the sequelae years down the road? And so without further ado, Patrick, please come up.
Thanks, Les. Thanks to the Academy. Thanks to all you folks out there. Without you guys, we wouldn't be here. So I'm last at the end of the presentation trail, and that kind of mirrors what it should be like in real life. When someone has pain, they have symptoms, I should be the last person that they see because, as we've all said, you start out with the least invasive measures, you work up that invasive ladder, and finish up with the most invasive treatment options, which are the most risky. So these guys did a good job with their presentations, and they do a good job in the community making sure you guys don't have to come to see me. Obviously, people do get to see me and do need to see me, and there's various reasons why they have to do so. They get told they need a surgical opinion. They get told by someone that they need surgery. They get told that they have an abnormal MRI. Frequently, after seeing these guys, I see patients because they've failed conservative treatments. They've failed the medications, the therapies, acupuncture, interventional pain procedures. And frequently patients see me because of red flags. We discussed red flags earlier on today, and we can talk a bit more about red flags. So these are some of the things that would kind of necessitate a more urgent referral to a neurosurgeon. Someone has a fever, they have an underlying infection. Infection can't be treated with conservative measures. You need to be admitted, have antibiotics. You may or may not need surgery. History of a tumor. If someone has chronic back pain or even acute back pain, and it turns out it's due to a tumor, you can't go with conservative treatments. You get admitted. You may need surgery. You may need radiation. Progressive weakness, unremitting pain, numbness. They may all be indications of significant nerve root compression, cord compression, which may need more urgent attention. And certainly bladder or bowel issues, again, urgent attention to decompress any compromised nerves. And certain traumatic injuries. If someone has a compression fracture in the back, and if it's unstable, you don't want to go down the road of conservative treatment, so you have to seek attention from a surgeon, and you may need surgical fixation. So when someone comes to see me, what do I want to know? I want to know their pain. Where does it go? Where does it start? Is it just in the back? Is it shooting down the leg? Is it shooting down both legs? One leg? Does it go to the knee, to the foot? I need to know that because it helps me figure out exactly what part of the anatomy is involved. If there's any numbness, weakness, any dexterity issues, balance issues, and the quality of life. Because most patients that will come to see me, typically it's a pain issue. So I say to them, well, how does it affect you? Can you sleep at night? Can you do your day-to-day activities, household chores? Can you play with your kids, your grandkids? Do you play pickleball? How are your interactions with the family? Are you socializing? Are you not? Because I tell them it's not a life-threatening or limb-threatening issue. Typically, it's a quality of life issue. All right. So I tell them that they can always choose to have pain or surgery for the pain, but they don't need to have surgery for the pain. But if their quality of life is affected to that extent, then sure, they can choose to have surgery for the pain. But it's not a life-threatening or limb-threatening issue typically. And patients that come to see me, imaging. Yes, imaging is nice to have. I don't always have imaging on patients that come to my office. They may have nothing, but that's fine. I will order it if I feel it's necessary because far too often there are problems with ordering imaging too early, and we can touch upon that shortly. X-rays, CT scans, MRIs, all useful to have, but not really necessary. They don't need to have all these imaging for me to evaluate them in the office. So moving on to problems with imaging, why is it a problem? You've heard a number of our speakers say that you should wait a while before you get imaging. One, radiation exposure. CTs and X-rays, radiation exposure. You want to minimize radiation exposure, so you minimize the amount of imaging you do. It may not affect your treatment plan. I order imaging when it's going to affect my treatment plan. If I see a patient, they're doing fine, there's no red flags, imaging's not going to change my treatment plan, I will not order any imaging. You have the direct and indirect costs of imaging. Direct to the patient, indirectly to the community, because the more imaging you order, the higher it is for healthcare, and therefore the higher your insurance premium is going to be. Increased frequency of MRIs are associated with higher rates of spine surgery. So you see something abnormal on an MRI, you're told you've got this diagnosis, you go to see someone that does surgery, he's going to treat that diagnosis, and they may not really be listening to your symptoms, and they get carried away with the imaging findings of the diagnosis, and they treat the diagnosis. I always tell patients, I'm not treating your MRI, I'm not treating your CT, I'm treating you, I'm treating the patients. So, just have to be a bit careful with imaging. This is from a paper in 2015. This is findings on patients after MRI. So this, at the top here, you've got the age of the patients, and here you've got the imaging finding. And let's take, for example, in patients in their 60s. These are asymptomatic patients, remember. They don't have any symptoms. But look at the frequency of pathology we're finding on their imaging. 88% of them are going to have disc degeneration. 67% are going to have disc height loss. Disc protrusion. I frequently, patients come to see me and I say, well, what brings you here? Why are you here? Well, I've got a disc bulge, I've got a disc protrusion. That's what your MRI says. I want to know what your symptoms are. So, 38% are going to have disc protrusion. So this is asymptomatic. So this is the frequency of findings you get on MRIs in asymptomatic patients. So that's why, we've got to be mindful of how often we order these and how we interpret them. You have to really listen to the patient when they come in and tell you their story, and not just look at the MRI results. So I think we touched upon some of these things earlier. When might I need surgery? If someone has severe unremitting pain, you try to be conservative and try to treat them with the least invasive measures because it's the least risky. But if someone's saying, look, I've had enough, I can't put up with this, and if there is a valid surgical option, then severe unremitting pain, that's an indication to go ahead with surgery. Neurological deficits. We want someone to remain a functional human being, reduce their pain, and make sure they don't have long-standing numbness or weakness, which affects their mobility or their ability to, participate in sports, etc. So we don't want them to have chronic neurological deficit, which limits that. Again, if someone has discomfort and doesn't really want to take the time to go through the conservative treatments, and they're unwilling to wait for symptomatic resolution with those conservative treatments, we're not going to punish you and say, look, go away, I don't want to see you. We'll try and help them out. And of course, if they've failed all these non-operative measures and there is surgical treatment, then we move ahead with surgery. So what makes a good surgical candidate? Well, again, failure of conservative treatments. Someone that has symptoms which correlate with their MRI findings. Frequently, I see patients, yes, they have symptoms. Yes, they have an abnormal MRI, abnormal CT scan, but there's no correlation. Symptoms in the MRI, symptoms in the images just don't add up. I can't offer someone a surgery if there's no correlation. Offering them a surgery is going to put food on my table, correct, but it's not going to help the patient. So, you have to have some correlation with the symptoms and the findings. Limb pain, leg pain versus back pain. It's easier. Limb pain is normally caused by pinching of a nerve or some instability in the spine, which is irritating a nerve, causes pain shooting down the leg. Back pain is more so due to degenerative disease, problems with arthritis in the facet joints. Limb pain is a lot easier to treat than back pain. Limb pain typically would involve taking pressure off of the nerve, removing some bone, removing a disc, removing some thickened ligament which is in the spine. And you can alleviate the pressure on the nerve, and that nerve can can recover, the pain decreases, and you feel much better. When it comes to back pain, it's much more difficult to treat. And how we typically treat back pain from a degenerative form is fusion surgery, screws and rods or spaces into the disc space. And, the outcome for that isn't always, it's not always a home run. It works, but it's a very invasive form of treatment. And in the right person, you get good outcomes. Focal versus widespread pathology. What I mean by that is you see on an MRI, if you have someone that has multi-level degenerative disc disease, virtually the whole of the spine, that's going to be widespread. We can't, like the orthopedic doctors, we can't give you a new spine. We can't give you a new hip, like they give you a new hip, a new knee, and you feel great after that. I see patients that have had hip replacements, knee replacements, and they're doing great. We can't give you a new spine. So when someone has widespread multi-level degenerative disc disease, unfortunately, there's nothing from a surgical point of view that I can do. If it's 1 level or 2 level, fairly focal disease, then a much greater chance of having a successful outcome. Young versus old, of course, if you're younger, you're going to have a better outcome. If you're a healthy young person, you're going to have a much better outcome. You're going to recover quicker. But that's not always the case. Degenerative disease, particularly these days, we're seeing it in the older population, and anesthesia's generally much safer. Surgery's much quicker, and patients tend to be a bit more healthier and a bit more active and can help with their post-op recovery. So, patients that are worried about having surgery later on in life shouldn't worry too much, because I see patients say, well, what about 10 years down the road? Shouldn't I get it done now because I'm younger? I'm like, if you're managing to cope with the symptoms now, your quality of life is fine, get on with what you're doing. If we need to do surgery in 10 years' time, we'll do it in 10 years' time. Don't worry, don't rush to it. BMI, your weight. Certainly, weight can be a factor when it comes to surgery. It can increase your complications, increase the time of surgery, increase your blood loss, etc., etc. People often say, well, if I lose weight, is my back pain going to go away? It may or may not. I see people that are skinny that have back pain. I have back pain. I wouldn't say I'm overweight, but I have back pain. So it's not necessarily always the case. But if you do lose the weight and you do come to need surgery, it'll certainly make the risks a lot less. You make your post-op recovery a lot better, and it'll certainly make it a lot easier for me to do if there's not so much weight involved there. Quality of life. Okay. I think that basically circles around to, if your quality of life is really affected, then surgery can be considered. If your quality of life is fine, you're able to do what you need to do, you delay surgeries for as long as you can. So some of the surgical options, I won't speak too much about them, but you have basically least invasive ones at the top, a discectomy where you make a little bony window, remove a little bit of disc cushion on the nerve, the foraminotomy, which is where you, again, make another bony window, take pressure off of the nerve. Laminectomy, you make a bigger bony window to take care of multiple nerve roots going down to the leg. The spinal cord stimulator was mentioned earlier. It's a neat device. And the good thing about spinal cord stim is it's good for back pain and leg pain. It doesn't care where your pain's coming from. And you also get it trialed before. The pain management guys will trial the spinal cord stim, and if it works, permanent one can get placed. Fusion surgery is the most invasive for chronic back and leg pain. You can't trial that. You have it done and it works, great. You have it done and it doesn't work, sorry. And the risk about fusion is it can work, and I've seen it work multiple times, but you run the risk of adjacent level fusion down the road because you've got a fixed moment arm at one level, which puts extra stress to the level above, extra stress to the level below, and you could run into similar problems 10 to 15 years down the road and you're back at square one with back pain. So you try and postpone those fusion surgeries as long as you can, if you can. Surgery, so what am I going to expect? The simpler procedures, discectomies, single level foraminotomy, you can go home the same day. The bigger surgeries, multiple level surgeries, you can stay at least one night. Rehabilitation, some patients may need a short course of rehabilitation. typically you return to regular activities around 6 to 8 weeks. Fusions, you require a brace, and you have limited activity for the 3 months while you're wearing their brace, then you start physical therapy. And I tell all my patients that once they recover from surgery, they need to get engaged in a regular exercise program. So they meet back up with their physical therapists, whatever therapist they saw beforehand, get re-engaged, a reminder of what they should be doing, and they continue with a daily exercise regimen in an attempt to prevent recurrence or worsening down the road. So basically, in summary, exhaust non-operative management. Symptoms have to correlate with imaging findings for you to be a good surgical candidate. It has to be a quality of life issue. If it's really disrupting your quality of life, then yeah, we can look about surgery. But if you're doing okay, yeah, try and hold off on surgery if you can. It's got to be focal pathology preferable. You're going to get better outcome if it's focal pathology. If it's too widespread, you're not going to be a good surgical candidate. And there are limitations and risks. We can't cure everything. We can't help with everything. We can't get rid of every single bit of your ache and pain. And yeah, again, stress the importance of having a regular home exercise regimen after surgery. You can't just rely on the surgery and that be the be-all and end-all. I see patients that may have surgery, do physical therapy, they do fine, they come back and see me down the road. Well, were you doing your exercise? Were you doing your therapy? Well, I was, but I was feeling good, so I stopped. If you'd carried on going, maybe you wouldn't be back here with me. So that's all I have to say.
Thank you, Patrick. Okay, that's it for our speakers. I just want to say Patrick's idea that we don't treat MRIs, we treat people, is kind of a tenet of patient-centered care. You know, it's not what's on the image, it's what's happening in the patient's life and what we find on exam. Couple things. We were pressed for time tonight, and you can tell we've already run over a little bit. And we were unable to invite an acupuncturist to speak. We were unable to invite a massage therapist to speak. We didn't bring any personal trainers here to speak. We didn't ask a pharmacist to speak. So there are a lot of other avenues to pursue the conservative management of back pain. But I think we brought you some good people. One other thing that we haven't mentioned, and I wanted to mention now, is that when you're considering where I might enter the system, who should I call? Who should I see? Excellus Blue Cross Blue Shield locally has a network of primary spine providers that they have trained and certified in the diagnosis and management of low back pain. And they're having trouble with their website, so don't go looking it up right now on your phone. But they have promised me they will have that directory up and running again. So if you want to look for somebody to start your journey to treat your back, I would recommend that as a great place to start, because they aren't going to give certifications to people who don't know what they're doing.